So let's start the next session. This session is mitral and tricuspid intervention. I'm Joo-Yong from Samsung Medical Center, Seoul, Korea, and my co-moderator is Dr. Sievert. And we have a very featured panelist, Dr. Chon, Dr. Chunhamaneewat, Dr. Hachinohe, Dr. Kang, Dr. Simon Lam, Dr. Lee, Dr. Lin, Dr. Lukito, Dr. Nuruddin, and Dr. Song. The first part is for mitral intervention, and we have 5 lectures. The first speaker is Dr. Shunsuke Kubo from Kurashiki General Hospital, Japan. His title is How to Apply TEER for Patients with the Small Mitral Valve Area. Shunsuke, please.
Thank you, Dr. Hahn. So first of all, I'd like to share this case. So this is an 88-year-old lady who have a history of the ischemic cardiomyopathy and the cabbage. So now he is NYH 4 class symptom on dobutamine. So T shows the severe MR, and we can see a gap here. But the problem is the mitral valve area is only the 2.9 square centimeter, and also we can see the leaflet calcification in the anterior leaflet. So the challenge is the TEER in the small valve area is the balance of the residual MR, the mean pressure gradient. So the previous study shows that both the residual MR and the mean pressure gradient can affect the clinical outcomes. So, but the patient in the small valve area it is difficult to balance both these 2 factors. So the expert consensus shows some of the anatomical suitability. So one of the factors of the suitability is the mitral valve area. The mitral valve area between the 3.5 and 4.0 shows the complex anatomy. And the mitral valve area 3.0 to 3.5 shows a very complex anatomy. And less than 3.0 is almost impossible for the TEER. But there is no data about the association of the baseline mitral valve area with procedure and clinical outcomes. So therefore, we conducted a study using the Ocean Mitral Registry. So this is a study flowchart. A total of 2,150 patients classified into 3 groups. Group 1 shows the small valve area less than 4, and the group 2 shows included the patient valve area between the 4 and 5, and the more than 5 including the group 3. In addition, so this group 1 divided into 2 groups. The very small valve area less than 3.5. And the small valve area between the 3.5 and 4.0. So this is baseline characteristics. So as you expect, is a small patient with a small valve area shows a higher age and a smaller body surface area. And also the mean mitral valve area is 3.4 square centimeter in the group 1. But there is no significant difference in the MR etiology and LVEF between the 3 groups. So this is the procedural result. So of course, the patient with a small valve area requires a less clip number. But as you can see, post-MR severity, so there is no significant difference between the 3 groups. But of course, the post-mean pressure gradient is significantly higher in the patient with a small valve area. So this is serial MR grade. So as you can see, in the both 3 groups, so MR grade was significantly improved at 1 year compared to the baseline. And also the proportion of the MR 3 plus or 4 plus was also similar between the 3 groups. So from this result, the small valve patient with small valve area obtains the efficacy of the TEER is similarly compared to the larger valve area. So this is serial NYH class. So in both 3 groups, so NYH class dramatically improved at 1 year compared to the baseline. But as you can see, the proportion of the NYH class 3 or 4 was a little bit higher in the patient with a small valve area. I think that this was affected by a little bit higher pressure gradient in patients with a small valve area in this group. So this is the clinical outcome. Surprisingly, the incidence of the death of heart failure hospitalization was similar between the three groups. So this valve area did not affect the clinical outcomes after TEER. So in addition, so when we look at the small valve area versus a very small valve area, so there is no significant difference in the death or heart failure hospitalization between the two groups. It's the same. So this is a summary slide. Actually, this paper was published in the SAC cardiovascular intervention last year. But the small patients with small valve area, so limited clip number, increase the mitral pressure gradient after TEER. However, the baseline mitral valve area was not associated with the post-procedure MR and clinical outcomes. So this suggests that only the small valve area is not a factor for the contraindication of the TEER procedure. So I think that it is important to use the one clip effectively in the patient with a small valve area. This is a case with the first slide. So the valve area is a 2.9. But as you can see, the MR jet, we can see the gap here, but actually the MR width is not so wide. So I think the NT was enough for this particular case. So I use the NT clip. The implant is the NT clip with this this gap. And after a one clip deployment, we can see only the mild MR. And the mean blood pressure gradient only 3 millimeters of mercury. It was acceptable. And another case, this is also the massive MR is a very wide MR, and we can see the gap here. But the mitral valve area is only the 3.5 square centimeter in this particular case. So we feel that XTW will be needed in this particular case. So we put the XTW for the SP2, and the residual MR shows the mild, and mean pressure gradient only the 5 millimeter mercury. So I think it is important to use the one clip is the most important position. I think a gap is important. So gap is a effective strategy. But it is also important to look at the valve morphology. In this case, also the mitral valve area is 3.5 square centimeter, the MR from the A to P2. But when we look at the 2D image, the posterior leaflet was not mobile, very rigid posterior leaflet motion. And when we look at the 3D image, there is no indentation between the P1, P2, and the P2, P3. So when we put the NT clip in this particular case, MR is gone, but the mean pressure gradient increased to the 11 millimeter mercury. So we aborted the procedure. So in summary, in patients with a TEER, a small valve area may limit the clip number and increase the pressure gradient, but was not associated with MR reduction and clinical outcomes. The mitral morphology, such as including the leaflet mobility and the indentation, is more important for to predict the stenosis of the TEER. So effective one device strategy should be considered in this particular case. Thank you for your attention.
Thank you for your excellent presentation, Shunsuke. Later, discussion is later. Yeah. The second speaker is Dr. Gilbert Tang from Mount Sinai Health System, USA. His title is Streamlining Procedural Workflow in Mitral TEER using Echo and Fluoro, Tips and Tricks.
Thanks very much for the organizer inviting me to give a talk on streamlining the workflow mitral TEER, because people still think it's a very difficult procedure, but I can see in Professor Takashi's live case earlier, it took only 5 minutes for him to do the procedure. So MitraClip G4 system, you can see here is 4 different devices, sizes available for optimal grasping. And the tip number 1, I would say, is how do you select what to use? I would say, like the live case, if the leaflet is long enough, we tend to use the wider and longer clip. However, use the shorter clip. But as I mentioned before, if the AP diameter is shorter, they will use the smaller device to avoid puckering an MR on either side. We typically use the wider clip to start, and usually one clip, as you saw in the live case, is sufficient to reduce the MR mild to better. However, sometimes with the broad jet, you need 2 clips when necessary. And when that's the case, we like to use a wide and narrow combination because it allows you to have a tighter fit between the 2 clips, and you don't have to run the risk of having a jet between the clips and also increase the gradient. We also like to measure the leaflets. It's important to measure the leaflet before and afterwards. Once you grasp, you can subtract the 2. More relevant in mitral than tricuspid so that you can see how much you insert. The other tip number 2 is the clipping strategy in primary MR. So we like to grab the entire flail segment or the prolapsing segment. And if the gradient allows it, we like to put a second clip so that you can actually stabilize the repair, particularly if your prolapse or flail is large. If the gap is too big, you might want to put the first clip next to the actual flail. Then you bring down the flail segment, and then you can do the second clip to grasp the actual pathology. If the posterior leaflet is very long, you might actually see an elbow after grasping, and the clip may cant after you release, so you need to prepare for that. Now, don't mistake cord as a leaflet. It can happen, especially in failed pathology. So make sure you grab the leaflet, and so they avoid the SLDA, and then time the grasping in diastole so that it can rest on the arm. Secondary MR is a little bit different. If the leaflet is long, as I mentioned before, you use the wider and longer clip. Plus, you have the added benefit of indirect annuloplasty like you saw in the live case. But if the coaptation reserve is poor, meaning the leaflets are kind of flat, you might need to grasp the anterior leaflet first, then quickly swing posterior while maintaining the orientation to grab the posterior. If the posterior is restricted, pointing down to the ventricle, you might actually need to have an aorta hugger intention to hook the posterior leaflet. And we like to grasp as much of the posterior leaflet as possible to create the annuloplasty effect. In atrial SMR, you may want to stay shallow on the clip so you can avoid getting stuck. And we like to say aim for mild or better MR. And if the patient EF is very low, just watch for acute afterload mismatch because the EF may go down further after you reduce the MR. So here's the clipping order we typically like to say. Outside in, you start with the commissures and you work your way in, depending on the pathology. Third tip is minimize the tidal volume in terms of respiratory motion so you can be more stable grasp. Avoid any volume overload. You might need to give diuretics during the procedure to reduce the gap. And also you want to maximize procedural efficiency to minimize the anesthesia time and probe manipulation time. So I'll show you a textbook case, actually not dissimilar to the live case earlier. This is a mixed pathology, A2 flail, and also reduced ejection fraction. So we first, by doing a sweep with and without color, you can see here, we look at medial, central, and lateral pathology. You can see where the flail is right here in the middle. You can see the patient has severe eccentric MR. We do a 3D on false view. You can see we look at clock face orientation. So you and the imager as an implanter can discuss the orientation of the clip appropriately because you don't want to confuse each other. We like to make sure the commissure is at 10 o'clock and 2 o'clock in the surgeon's view. So here's the clip orientation. You want to see, for example, in this case, it should be a 12-6 orientation. So you want to make sure the commissures are 10 and 2 so you and the imager can agree the clip orientation is proper. We like to use fluoroscopy. I know some people don't, but we like to do that because you can actually really tell the orientation and trajectory on fluoro plus echo, especially your echo imager is still learning. So what it means is that you should follow the green arrow. It goes straight into the ventricle in the same direction orientation. If you go up, that's a lateral dive. If you go down, it's a medial dive, so that's no good. How you see that on echo? Same thing. See, on the bicommissure view, you go straight down on the green arrow. In the grasping, you go straight down in the AP direction. If you go that way, it's a posterior dive. This way is anterior dive. You can see a lateral dive and medial dive, so you avoid all those possibilities. So when you go in, we like to do it close so you don't get the gripper get stuck to the leaflet, particularly if it's primary. So you can see it goes in straight. You don't want to go into with a direction of the dive. How do you know you dive? You put an imaginary line on the annulus and the annular plane, and you make sure you go straight down perpendicularly. So on Fluoro, you can do the same thing. When you come up, you should make sure the clip has not rotated without parallax. You can see that here when you come up the grasp, especially when you do independent grasping. So here's example. You can see we're in the ventricle. We're now coming up the grasp. You want to make sure see the clip at the level of the leaflet. And you want to make sure you drop your gripper slowly so the imager can record actually when you actually drop to confirm insertion. So when you close, you want to give back tension because remember, the mitral valve coaptation is below the annular plane, not above. So you want to make sure you close slowly and maintain that and you give back and you can see, make sure you don't lose any leaflet when you close. Then you look at the tissue bridge on your 3D and you check the gradient and pulmonary vein flow. And this is the final assessment. You can see that one and done. Very excellent result here. And you can see that here. And also on the fluoroscopy, you should not see the clip rotate when you release. If you do, that means you twisted the valve and you might have a problem. Now, what about primary MR case? This is a very broad flail. You can see that here, torrential MR. And you can see that here, again, we do the same sweep. You can see the cursor bicommissure X-plane. This is more medial. You can see start medial to central. And you can see we do the first clip more medially, XTW. And you can see that here, when we grasp, you can see the elbow. Okay, so we actually had to go more posterior to grab where the elbow is and before we drop the grippers. So that's very important. If you, even though the leaflet is long enough, if you don't grab the elbow, you're going to see a big rock. So the grasping is that you want to enter the LV close, grasping diastole, avoid the segment getting stuck to the grippers, and you try to grab as much as possible and use a second clip to stabilize. So here you can see nice bounce on the grasping, on the grippers. Look at when you close, you can see that there's a bit of an elbow here, right? We lose some leaflet. So that is a concern. So we immediately put a second XTW there. There's a very big flail. So that's why we use WR and a narrow clip. You can see that now. You can see how close we are on fluoroscopy. Make sure there's no rotation of the first and second clip and stay exact parallel. And you can see here, we needed that to stabilize the result. So you can see the reason why you see this cant and the band is that the posterior leaflet is extremely long. So you can see that you need to be account and ready for that to happen. Now, what about if you don't have enough height? This is called advanced steering. You can see you can gain height by doing first the A knob. So A knob deflects the clip away from the annulus, and then you basically add more M, and you can see how this works here. And then you go and TEER guide talk to bring it back to the annulus. So that's the last step. Okay, so this is a very useful advanced steering feature, especially if you don't have enough transeptal height. So in summary, the mitral clip G4 system can be done safely, efficiently. You can see with excellent MR reduction. The key is the TE guided but flow assisted, and it's highly standardized. You first standardize the TE acquisition in terms of screening and the procedure. Both the imager and implanter need to know TE and fluoro at all times. But you have to be very careful about rotation during entry and grasping, and also inadequate leaflet insertion to avoid. And if you don't optimize appropriately, you can run the risk of SLDA. Thank you.
Thank you, Dr. Kang. The next speaker is Dr. Ono from Tokai University Hospital, Japan. His title is How to Deal with the Patients with the Severe MR and a Severe TR.
Thank you for your kind introduction. So for the sake of time, I would like to go straight into this clinical scenario that we quite often encounter in our daily clinical practice. So when I started my journey of mitral TEER back more than 10 years before in Catania, Italy, one of the clinical questions that I had was, how should we deal with patients who are combined with significant TR when undergoing for the mitral TEER procedure? As you know, some of the patients actually have significant TR at the baseline. This was the early study we did in Italy using the GRASP registry. The patient number was only 150 or so. Well, 1/3 of the patient had a moderate or severe TR at the baseline. And it was actually associated with a poor clinical outcome. The freedom of death and rehospitalization by heart failure in patients with moderate or severe baseline TR group, was worse. But interestingly, the baseline significant TR, some of the patient improves after mitral TEER because of the left ventricle unloading due to MR improvement. But still, with this limited number of patients, we were not able to identify some kind of predictors who will be improving and who will not. So, and with this clinical questions, if the patient with a significant TR has poor clinical outcome, why not do with a combined tricuspid TEER as well? So some of the data suggests that combined mitral as well as tricuspid TEER approach has a better clinical outcome. Although, like shown in this case, a limited number of patients still is kind of cannot give a robust conclusion. So we tried to deal with this clinical question using our recent updated Ocean Mitral Registry, which included 3,764 patients, quite a robust number of patients and data set. So with this baseline patients, 1/3 of the patients, a little bit more, actually had baseline TR, baseline significant TR, which we defined TR with more than moderate. To start with. As we provide a good optimal mitral TEER procedure, and along the follow-up, patients, this mitral TR grade changes over time, as you know. So even with the patient with no TR at the beginning, some patients, like 9%, has new onset TR when we go for the follow-up. Whereas when we start with a baseline TR, about 1/3, a little bit more, normalize after the mitral TEER procedure. And this TR is really dynamic. So start from the baseline, post-procedure, just before discharge, at 1 month and 1 year, the TR is really dynamic, and it varies from patient to patient. And we were happy to share our data, which was recently published in European Heart Journal. And as for the baseline, as I mentioned, we divided into 4 groups: baseline no TR and baseline TR. Both of these groups has evolution of the TR, no TR, and new onset TR at the follow-up. Patients who had baseline TR, normalized TR, and the residual TR. So as for the baseline characteristics, patients with residual TR were more likely to have a higher age. As for the New York Heart Association heart failure status, there was no significant difference among the 4 groups. As for the LVEF, patients with residual TR group had a significantly higher LVEF, which suggested the etiology of the MR and TR in this patient population is mostly related to AFib. So, as I just mentioned, patients with residual TR had the most frequent patients with AFib. And they were also had a lot of patients, majority of the patients were on loop diuretics. As for the right heart status, it's easy to speculate, but baseline TR patients had dilated right ventricle as well as the dilated annulus for the tricuspid. As for the RV function, patients with baseline TR had a little bit poor RV function, which we identified with RV FAC, so on. Acute procedure success, the highest group was with baseline no TR, and the lowest in this group was residual TR, probably due to patients, most of the patients had atrial secondary MR etiology. So post-procedure findings are shown here. As for the post-procedure gradient, there were no significant difference. However, patients who had residual MR gradient, MR more than moderate, equal or more than moderate, in patients with residual TR and new onset TR group had a worst outcome. So in this study, the primary endpoint was a combined endpoint of cardiovascular death and heart failure hospitalization. As you can see here, in all combined, as well as each subset of endpoint, patients with new onset TR had the worst clinical outcome. The next was the residual TR, and followed by no TR and normalized TR group. We tried to identify the association using this spline curve analysis that whether the baseline or the post-procedure and follow-up tricuspid regurgitant pressure gradient was associated with the event. So as you can see here, baseline TRPG was not associated with outcome. And more importantly, post-procedural and follow-up TRPG was strongly associated with event. So thanks to this large-scale data set, we were able to identify some important factors that was associated with post-procedural new onset and residual tricuspid regurgitation. As speculated, AFib played a critical role in this setting, as well as dilated tricuspid annulus. So this is the highlight of this paper. As we went through, the grade of TR as well as tricuspid regurgitation pressure gradient is really dynamic after the procedure, and it was related with outcome. In conclusions, careful TR assessment before and after the procedure would provide an optimal management for concomitant significant TR in patients undergoing mitral TEER. Thank you for your attention.
So congratulations for your excellent work, Dr. Ono. The next speaker is David Cohen from St. Francis Hospital in CRF, USA. His title is Prediction and Prevention of LVOT Obstruction During TMVR.
Thank you so much. It's really a pleasure to be here. And I want to give a lot of thanks to my colleague, Jaffer Khan at St. Francis Hospital, who taught me a lot about this, this problem. These are my disclosures. So we'll start with a case, 86-year-old woman. It's fairly typical, 6-month history of exertional dyspnea, New York Heart Association Class 3. She has a history of HFpEF, hypertension, and atrial fibrillation. And her echocardiogram shows normal LV function, severe mitral annular calcification with severe mitral stenosis with a valve area of 1.2 and a mean gradient of 14. Her operative score, STS, predicted risk of mortality, puts her in the high-risk range with about an 8% mortality. She certainly doesn't want to have surgery. And so we're trying to figure out what to do with this woman. This is an echo we've all seen before with very, very severe mitral annular calcification. Not too much in the way of MR and TE confirmed that, but again, a very high pressure gradient. So we want to treat this with a valve. The issue, as those of you who do transcatheter mitral valves in a variety of different mechanisms, is that a lot of patients anatomically are not suitable. This is the Summit trial, which was with the Tendyne valve, and a summary of all of the screen failures in that trial. And you can see here that about 65% of the patients who were evaluated for consideration of the Tendyne valve failed screening. And the most common reason by far for failing screening was a high risk of LV outflow tract obstruction. That is really one of the main barriers we have to being able to treat patients with transcatheter mitral valves that we have now and ones that we may have in the future. Although I think Juan hopefully will come up with some good ideas. So what's going on here? We have a number of issues with the mitral valve. Really, the mitral valve itself is a miraculous invention, if you will. But we have two main mechanisms of left ventricular outflow tract obstruction that we have to worry about. One is physical obstruction of the frame of the valve, where the skirt will hang across the LV outflow tract and come close to the interventricular septum, causing physical obstruction. And then in addition, if there's an intact anterior mitral valve leaflet, as we will see in a patient with MAC, that leaflet can hang over the valve frame and cause even further obstruction in a dynamic fashion due to impingement on the septum. And this is the anatomic problem we're dealing with. This is a post-surgical patient. But what you can see here is the aortic valve. Here's the mitral valve. Both are bioprostheses. And here is the anterior mitral leaflet, and the problem is if we were to treat this with a valve-in-valve, for example, in this case, it will push the anterior mitral valve leaflet into the LV outflow tract and can cause obstruction if the outflow tract is relatively small. Over the years, a number of different predictive factors have been identified that we can look at mostly on CT, but also on echocardiogram that predict left ventricular outflow tract obstruction. And by far the most important one is what we call the end-systolic neo-LVOT, a measurement we make on CT and end systole with a valve, simulated valve in place to try to estimate what the area is going to be in that left ventricular outflow tract. There's a number of different cutoffs that have been proposed, but somewhere right around 200 millimeters squared is where the risk starts to really go up. If you have over 200, and certainly if you have over 250, there's very, very little risk here. And this is the main thing that we look at when we do these CT analysis. So here is a CT analysis of a patient. You can see they have a bulging intraventricular septum. Here's the aortic valve. Here is the mitral prosthesis that we're simulating, and you can see that the edge of the frame is coming right up to the edge of the intraventricular septum, and if we assume that there's going to be anterior mitral valve leaflet covering that, you can see this area in here is 60 millimeters squared. So this patient is very, very likely to have high-grade left ventricular outflow obstruction if we just go in willy-nilly and put in a valve. So how do we treat this once we've identified that the patient is high risk? Well, there are two basic techniques because there's two things that cause the obstruction. One is to change the septum, and the solutions here are things that are going to shrink the septum. So traditionally that has been alcohol septal ablation. In some cases, radiofrequency ablation, although that's got a very high risk of left bundle branch block and pacemaker, and newer procedure called the sesame procedure I'm going to highlight in just a moment. The other option and the other possibility is to modify the anterior mitral valve leaflet. If that is part of the problem, if it's still there, and it's going to be hanging into the left ventricular outflow tract, causing part of the obstruction, we can do things like lampoon. We can have surgeon come in and just resect the anterior mitral leaflet. We can do a Batman procedure where we put the valve through the anterior mitral valve leaflet. And then there obviously are different designs of transcatheter mitral valves that might reduce the likelihood of obstruction. Just a word about the sesame procedures. This is something people have heard about. I've been lucky enough to stand there holding wires while Jafar Khan does a few of these. And so it's really an amazing procedure as far as I'm concerned. So this is a cartoon of it. We have already penetrated into the intraventricular septum with an Estado wire that's electrified. And now we are just steering the wire under fluoroscopy through the intraventricular septum. And then we re-enter the left ventricular cavity where we have a snare parked. We snare the wire. We externalize it just like we do for basilica or pretty much any electrocautery procedure, electrosurgical procedure. Then we electrify the wire and we pull it back gradually and we create a slice through the intraventricular septum. And this is, if I can get this to advance, this is what it looks like clinically. So the first step is we have a JR4 or a similar guiding catheter, which we engage right up against the intraventricular septum where that bulge is right here. You can see it coming through the valve, and then just under the valve, you have to really get right under it. And then you enter the intraventricular septum with it electrified. The next step is kind of where the magic happens, as far as I'm concerned. Under pure fluoroscopic guidance, you have to sort of guesstimate your way through the intraventricular septum based on landmarks that you created using CT. So it's a fusion type procedure where you have CT, at least in your head, and then you're simply navigating this with the wire without electrification, just spinning the wire back and forth. It actually moves relatively easily. Then we re-enter the left ventricular cavity. In this case, you can see is re-entered by the ventriculogram. We usually confirm this by echocardiography. And then a really critical step, the most critical step actually, is to find this wire all the way along the septum by echocardiography to confirm that it is not too close to the right ventricular border, because if it's too close, then you may have a VSD. Then here is the laceration being performed. And this was an amazing case. I mean, it doesn't usually look like this, but you can see this very, very nice slice in the intraventricular septum here, and it heals even better. The other procedure that I mentioned is modification of the anterior mitral leaflet with lampoon. This is a procedure that there's two different versions of it. There's a tip-to-base version, which you do if there's something, either a valve or a ring in place so that you can't pull it all the way through the aortomitral curtain. If, on the other hand, you have a native valve like we did in this case, then you have to do base to tip, where we actually put 2 catheters through the intraatrial septum, perforate the anterior mitral leaflet, snare it, and then pull it the other direction, so we're protected. Here is a case of the base to tip lampoon. You can see here we're traversing. You can actually see just some bubbles just at the very end here, which will appear as we're getting the wire just across that anterior mitral leaflet, the A2 traversal. And then here is the laceration after we've created the flying V. We're just pulling, 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 pulling. And you'll see it pull through at the last second. Here, there it goes. And in this case, again, this was really a perfect example. You can see a very nice cleft in the anterior mitral leaflet. And so just to summarize, sort of the algorithm we use to think about managing the LVOT if there's high risk of obstruction. The first thing we do is we measure by CT, that neo-LVOT. If it's greater than 200 millimeters squared, we're all good. And we can proceed with some form of TMVR, and that's what we would do. Just go ahead and place the valve. Usually these days a Sapien valve in MAC, but other countries may have access to the Tendyne device. We don't have it yet. If you have a small neo-LVOT, then you need to measure what we call the skirt neo-LVT, which is where the skirt of the valve stops, because again, the open frame, at least of the Sapien valve, is not obstructive as long as there isn't an anterior leaflet across it. So if the skirt neo-LVOT is greater than 200 square millimeters, then all we have to do is take out the anterior mitral leaflet and we can obtain this measurement. If the skirt neo-LVOT is less than 200 millimeters, we have to do something else. So if the anterior mitral leaflet is a problem, then we do lampoon, as we just saw, and then we can proceed with valve and MAC. On the other hand, if we have a small skirt neo-LVOT, we have to modify the septum, so we can either do alcohol septablation or, in these days, most commonly sesame. Repeat a CT after 4 weeks to 6 weeks to see how that is healed, reassess the neo-LVOT, and hopefully you're in a good shape to proceed at that point. And that's where I'll stop. Thank you very much.
Thank you, David. The last speaker is Dr. Juan Granada from CRF USA. The title is Transcatheter Mitral Valve Intervention. What is next?
Thank you for the introduction. And in the next 8 minutes, I'm going to provide an overview of where the innovation field in mitral technologies is going. The first thing that I'm going to say is, if we go back to the history of mitral innovation, I think it's fair to say that over the first 40 years of the surgical field, starting in 1960, all the efforts were focused on mitral valve surgery techniques and actually technology. So innovation was very, very slow over the first 40 years and focused on primary MR in low and intermediate risk patients. As it happened in TAVR, significant unmet needs and opportunities were left behind, including high-risk surgical cases and SMR patients. Also, actually, patients with severe MAC and poor TEER anatomies. And around 2000, a second wave of innovation started with catheter-based techniques, including mitral TEER and Sapien valve in valve and valve in ring. One of the things that I want to say is that now today, what we're trying to address is not really all anatomies, but essentially patients with very complex disease with limited therapeutic options and high risk for surgery. And this is where innovation at the very beginning, as it happened in TAVR, is actually putting all the efforts on. I like to put this slide because it shows the natural history of severe MR when it's untreated. This is a study that included approximately 1,000 patients with 3+ MR and heart failure. As you can actually see here, patients with primary MR, most of them had surgery, as usually happens in the real world. Patients with secondary MR, most of them were treated medically. Patients untreated typically had lower EF and higher STS score. And it's interesting to see that when these patients were followed up to 5 years, you can see the high mortality rates and rehospitalization rates of these patients. So this is actually truly an unmet need that needs to be addressed. One of the issues with transcatheter mitral valve innovation is that it's driven by anatomical needs, which is different than TAVR, that once the design pretty much is finished to anchor the device in the aortic valve, pretty much it's fair to say that with some variations, most of the valves actually work. Actually, here we have on one spectrum technologies like TEER that depend on specific anatomical features. And on the other actually extreme of the spectrum is TMVR that at least claims that is more agnostic to the anatomy, with several technologies in between that require specific anatomical characteristics. For this to work in the future, though, technologies need to be simple, easy to use, especially on the imaging side of things, and obviously have long-term technical performance. One slide about TEER. TEER, at least in my view, is a highly standardizable procedure, but not necessarily reproducible. Once people get to know, 90% of the people, almost everybody knows how to actually do it, but it's very volume dependent, and it depends on the volume and the aggressiveness of the operator. You actually see that residual significant MR, happens in 30 to 40% of the sites. Also, TEER performance in complex anatomy is a balancing act. In low volume centers, TEER has excellent safety profile with very good outcomes. In high volume centers, they actually get very good efficacy results. But it all depends on the number of clips and how aggressive the operators are. And I call it a balancing act is because you have to choose leaving residual MR behind or a patient with a high gradient. For me, the future of TEER depends on three main things. Number one is that we get better on imaging-based prediction models of technical success. The device evolves to allow the use in broader anatomical variations and actually have some level of reversibility where the clip can be removed and other technologies can be used in the future. We also now have technologies that are trying to go in between replacement and repair with the technologies that essentially produce partial repair of the valve. This is one of the examples that is called the half-moon device, in which a posterior leaflet stopper or a leaflet augmentation device is actually put in and essentially allows a better coaptation of the anterior leaflet. First in human study with this and other devices are already under advanced investigation. On the other spectrum is TMVR, which the value proposition is ease of implantation, agnostic to the etiology of MR, reliable elimination of MR, and less recurrence of MR. The reality is we started with an idealized world of how the design should really work in most of the patients, but in the real world, we have so many anatomical variations that limited essentially the use of this technology in most of the patients. David actually presented some of the data that we generated also from Europe with the Choice and Mice registry, and at least we know that a third of the patients were essentially screened out of TMVR studies because clinical reasons, and two-thirds due to anatomical reasons, being LVOT obstruction and actually valve areas not having the valve for the type of areas that would require the main limitations, in these first-generation technologies. The good news is new TMVR platforms continue to evolve, and they are getting smarter, and actually new devices and new iterations of previous generations are now, ready to address some anatomical issues, such as low-profile valves, different annular sizes for small and big annuli, and smart delivery systems that can overcome the septal height limitations. This is a summary of all the EFS data that has been done in the US so far. As you can see, we already have some benchmark data in a small series, and we know conversion of surgery is between 3 to 4%. Major bleeding complications in new generation devices is actually very low, and you have a mortality at 1 year that continues to improve again in a small series of patients, but we started to get this important data that is going to help to plan future studies in the future. One of the things that David showed, I really am a believer on, and is evolution of adjunctive interventional tools is going to enable the treatment of more complex anatomies. This is a case we did with Azim Latif, for example, where this patient had a failed Alfieri stitch, recurrence of MR, and essentially we cut it with electrosurgery and then put a TMVR device with an excellent clinical result. So we're going to see a lot of these ancillary tools essentially helping at least the TMVR field to move forward. I'm confident within the next couple of years, we're going to have some studies completed, big pivotal studies, and a couple of devices already approved in the US, which is going to help to continue to push the field forward. So how can a transcatheter mitral valve intervention technology address the clinical need? I think that we all agree that versatile, low-profile transseptal delivery systems is the way to go. We need to actually do a better job defining the target population and predictors of outcomes, because not every single anatomy can be actually be the recipient of every single technology. We need adaptable device designs to the human pathology and decrease the number of rejections that we see in these trials. We need ancillary tools to improve the success rate of TMVR devices. And the last thing that is not really inconsequential, and we need to pay very close attention to it, is strategies to manage the thrombogenic potential of these devices, especially on the replacement side of things. Thank you again for the invitation, and this is all they have for transcatheter mitral valve innovation.
Thank you, Dr. Granada. We have about 10 minutes for discussion. Is there any comments or questions from the panel or audience?
I have a question to Dr. Ono, talking about combined procedures, mitral and tricuspid. Maybe you said it and I missed it. Did you try to use tricuspid sheath for the mitral intervention?
Actually, to tell the truth, in Japan, we finished the clinical trial of tricuspid TEER, but it's still not commercially available. So at this moment, there's no option unless we go for the off-label use for the tricuspid intervention.
Anybody else has used tricuspid sheath for mitral intervention?
Yeah, yes, we did have experience using the tricuspid sheath to do the mitral intervention. I think it's quite feasible and also safety. And even comparing to use the mitral guide, using the tri-clip guide, actually the requirement height might not be that much as using the mitral guide. So I think it's quite feasible using and also the steering mechanism, the SLR can also increase a high. If you have aortic hug issue or high issue, you can also apply the SLR to improve the high issue.
Do we still need the mitral sheath then?
Yeah, I think probably we don't need mitral sheath, but I think we need a clinical trial to prove that.
In experience, for sometimes because the tip is very short for the tricuspid, the plus and minus doesn't work that well. So it's very extreme commercial prolapse, and that would be a big problem. But then you don't want to get in the sheath out and for bleeding issues. So I think tri-clip guide is good for most of the cases for combined procedures.
Mm-hmm. Any other questions, comments?
Yes, thank you. This is about the post-TEER monitoring. What are your recommendations for post-TEER monitoring image in terms of follow-up of the frequency and the modality, TTA or versus DEE or CT?
So question for Dr. Ono?
For all the
Probably
speaker.
Dr. Tang is probably the right person to answer that. Where is he? Embolized? Who else would take that question? So follow up after mitral clip is your question, right? Yeah. Simon.
I would say, I mean, I can take it if you want, or
Oh,
you can let,
okay.
Simon, you go.
Yeah, no, you go.
I mean, it's clinical first, because that's what we're treating, is a clinical problem. So are they feeling well? Are they, have they had return of symptoms since they had the clip? And then it's purely echo is the only thing we follow, looking for, substantial increase in the either MR or in a gradient. But again, what would prompt us to re-intervene, other than for an SLDA, for example, would be typically if the symptoms are getting worse. Because again, that's largely what we're trying to treat for it. And we don't have a lot of good data on repeat mitral clip. The publications are fairly small, although we are working on one from the TVT registry that will have several thousand patients in it. So hope to show you that soon.
So he is basically saying there's no need for cardiologists to do the deep follow-up. It can be done by GPs, right? It fits well into the German healthcare system.
Can I just ask a question, a practical one? If you have a large flail and with one clip, the MR is greatly reduced, do you put a second clip to stabilize the first clip if the gradient is fine and the mitral valve is all right? Because there's always a fear that with a large flail, one clip, although you get a good result, later you might have problems. A second clip to stabilize. Does anybody do that?
We don't do that, but maybe other opinions. So if you mean if the result is good, there's no residual MR, would you have to implant a second clip? Juan?
This is a very, very important question because the answer is no, except when you have a very long anterior leaflet in presence of mitral valve prolapse. And this is when you see actually all the studies, dislodgement SLDA of the clip happens, especially in those cases. So this is where, at least, and this is not really evidence-based medicine, but operators are trying to stabilize the first clip when you have a very long anterior leaflet or mitral valve prolapse to actually avoid exactly that.
Or if you are not sure about the leaflet insertion, did you grab enough of the tissue? That could be another reason to implant a second clip. Yeah. Okay.
Can I have one? Yeah. One question for Dr. Granado. This is regarding you showed a lot of innovative mitral stuff, and probably we'll move to the tricuspid. But obviously, this won't be backed up by the vast amount of data that we have in severe areas for TAVI. So how will we get approval for these kinds of very critical, small-numbered patients with these kinds of innovative devices? How will these devices approach the patients?
So you're talking about the clinical pathway?
Yes. How
so this
will
is
they
a
get
good
approved?
question. This is a good question for David. So what is happening in the U.S. is most of the studies, are single-arm studies in patients that are high surgical candidates, primarily actually MAC. These TCT, we're going to have the formal presentation of actually a couple of pivotal studies. And this year, we're going to see at least a couple of presentations of these single-arm studies that at least are going to provide the baseline data, in terms of feasibility, safety, and performance. I know that actually David wants to see randomized controlled studies. That's the right way to do it. But as you can actually see, it's very challenging to do these studies because, logistical and actually also operational issues.
Yeah, I think Juan said it very well. I think the initial approvals, and very likely many of them that get approved for the high-risk, inoperable type of patients, these MAC patients that we're talking about, which are so difficult to manage with TEER, will be single-arm studies just by virtue of there is no good comparator other than medical therapy. You could do that, but I think most people are pretty convinced that that's not the right thing for these patients if it's very severe and quite symptomatic. I think where it will change, in my estimation, is if we ever get to the point where these technologies have evolved and the techniques have evolved enough that we want to compare against surgery. Then I think, if we go into lower risk patients, then we're going to have to do trials against surgery, just like we did with TAVR. But I imagine those are many years away. Surgery is pretty good, pretty tough competitor there. So I think we've got a ways to go yet for that.
Because both of you are so close to the microphone, these lampoon technique and sesame, great techniques, but this could not be the ultimate goal. So you look through all these new valves, which of them has the lowest risk, theoretically, the lowest risk of LV obstruction, of the new valves coming up?
So this is actually a tricky question because two-step approach devices, the ones that are used in cinches, Tioga, High Life, M3, and several others, because they have a straight funnel, they protrude less into the LVOT, but the problem is because they land lower, they may essentially push against the septum. Low-profile valves, such as, for example, Cephea with Abbott, they land very high, but if you don't capture the anterior leaflet, then the anterior leaflet is going to essentially have the parachute effect, and this is where lampoon may be important. I honestly don't really think that any valve is going to be able to overcome 100% the LVOT obstruction. That's for me. And remember, the surgeons, when they do mitral valve surgery, typically also sometimes they prepare the septum or the leaflet. So I really think we're going to have to get used to it that in some cases, and I don't know if it's going to be 10% or whatever the percentage is, we're going to have to actually learn how to implement these techniques into the TMVR field.
I should have asked more precisely, which of all these techniques is the best one? Not 100%.
I think sesame, for me.
Okay, but avoiding any LV obstruction. Which of the new valves has the lowest risk of LV obstruction? theoretically?
I mean, in theory, I mean, again, I think it's going to be very anatomy specific. 4C in theory is not in the LVOT, right? It's in the atrium, but it's moved very slowly through the pathway. I don't know where that stands. Juan maybe can answer that. We should just have a tag team here. But the Cephea has a fairly low profile.
I think Cephea 4C.
Yeah.
Okay.
Those are the ones.
I have a question to David Cohen about TMVR, valve-in-valve TMVR. Recently, I evaluate valve-in-valve TMVR candidate patient that CT analysis simulated LVOT area is over 200 millimeter square, about 220, 30. But the simulated cross-sectional morphology is very eccentric. It seems like crescent moon. So I worried about the dynamic obstruction after valve-in-valve TMVR. How about your opinion and morphology of LVOT?
I mean, it always ends up a crescent to some degree, right? I mean, that's always the nature of a round valve pushing up against the septum. So I think, I mean, just the shape shouldn't be the sole determinant. You have to be sure to really measure in mid-systole, right? Because it's all very dynamic. But if you're that worried, again, it may make sense prophylactically to treat the septum before you go ahead and do something. If you're very much on the fence, I know some people who are very confident with Lampoon or with sesame or alcohol septal ablation even will treat the septum if the predicted neo-LVOT is less than 250 millimeters squared. So there are some people who would treat that septum. But it's a matter of your comfort level with the techniques. Do they have, if you want to do alcohol septal ablation, do they have a good septal that's there? Is the septum sufficiently thick for sesame? Sesame, the main complication we're worried about when we do that is causing a VSD by being too close to the RV. So you need to have, and what we try to look for is to make sure we are always at least 8 millimeters away from the RV over the entire length of the septostomy. So all those things go into planning. Sesame is it is a really unique procedure. It is a very interesting procedure, but it is incredibly imaging intensive. The CT is the whole thing, as far as I'm concerned.
Thank you very much. I think we have to move on to the second part of this session. Simon Lahm will talk about TEER or TTVR, how to decide.
So thank you. This topic is about TEER or replacement in a tricuspid position. So first of all, we know we have good tools for edge-to-edge repair for mitral, and this technology has transferred to edge-to-edge repair in tricuspid valve. Selection for device include TriClip. We can do MitraClip and off-label use to tricuspid region. We can use Pascal in China. We can use Dragonfly. So we know the design. We have 4 choices to choose from for the keep arm width and length. Usually we would choose the bigger and longest one because of the leaflets, coaptation, and also the longer leaflets that we've seen in the tricuspid region. So first to share with case on the typical case for TEER for tricuspid position. And this is a patient with, you can see, dilated tricuspid annulus and it's severe functional or torrential functional TR. And we need to do imaging. So TE is the standard of care. We have to get this info-outflow view with the X-plane showing the relative relationship. For example, if you do the X-plane near the aorta in this region, you can separate the septal and the anterior leaflets. And you put it more to the side, and you will separate the septal and posterior leaflets. So you need to know the target that you're focusing on. And this is a very important view in transgastric view for tricuspid regurgitation for TEERs because it helps with your leaflet grasping as well. Sometimes we confirm it through this image view. So we usually, it's an isolated TR case, we go from the left because for the better trajectory, gain space, and for the device to work on tricuspid annulus and could avoid septal hugger in most of the cases. So eyes is important because we know the imaging problem with tricuspid edge-to-edge repair. At the leaflet level, we rely on the 3D eyes because you can see where you are positioning and how you really visualize the capture. So 3D MPR also very important for TEE, especially for nowadays. You don't want to miss it by just a wrong X-plane orthogonal angle. You need a really three-dimensional assessment before, during, and after the grasping. And transgastric view is why important because sometimes the images are not good. You can see that you have leaflet restrictions from a transgastric view, and in this case, we have captured the septal and anterior leaflets at the commissure. So you can see also the position, restriction of leaflets, and reduction in tricuspid regurgitation. And the rest is usually reproducible. Usually we need one more clips, or sometimes 2 or 3, and you just repeat everything that you have done, imaging, meticulous assessment, deployment, and usually we have very good results like this. So this is a transgastric view showing the results and the residual. Usually you can at least decrease the grade of TL to 2 grades, and sometimes, like in this case, we can achieve mild TL afterwards. So the second case is very quick, is patients with pacemaker leads, and I think it's common because lead itself could be a bystander in a setting of a tricuspid regurgitation, could also be the culprit of sprinting of leaflets, pressing on it. There are different mechanisms and their classifications, and we have to know their techniques and what are the mechanisms to plan our procedure. And this case is still quite mobile for the leads. So for clipping, it's one of the good options because we can know where exactly the leak is, and we can do some endoplasty effect. And you can see this is a transgastric view. We have good alignment. You can see the lead is moving towards in the middle. So we can do the same thing for a native Mitral tricuspid regurgitation without lead. Also go through the meticulous imaging assessments. So first clip was deployed. The lead is moving more to the middle. And then the second clip is deployed, and then also moving the lead to the middle. So this is how it works. First of all, try to locate where the tricuspid jet is, and also do some endoplastic effect to improve the TL. So for tricuspid replacement in Asia Pacific region, I think more will be on the lux valve. Although we know more about looking forward to the EVOQUE, for example, which is FDA CE marked. And but then this is one of the experience that you can see this kind of leaflets coaptation is definitely not suitable for TEER. You can see the gap is so wide, and maybe you can do some commercial clipping, but result may not be that good. So it also precludes your future option for replacement. So that's the reason why for this kind of case, we're screened with CT scan to see if it's eligible for replacement. Then if it's suitable, then we go directly to replacement. You can see this kind of ultra-torrential TL is definitely not too suitable for clip. So technical details will not be covered here, but this is how those techniques work. So the replacement go for the transjugular using the lux valve. You also need to visualize the anchors, the positioning of the septal tongues, and release step by step, also on TE and ICE guidance. And this is how it looks like. So what about how to choose? It's difficult because it really depends on the availability of the device, the techniques that are going into the particular market, and local experience. Data supports have a good support for TEER with good results, and in terms of reduction of regurgitation and also improvement in symptoms. And also there are data coming up like the Transcatheter which shows also a promising direction for replacement. So how to choose? But go back to surgery. I think replacement is always the second thing to think of. Repair is still the golden rule, no matter it's a mitral or tricuspid area. Not only that, the results is better tolerated by the patient, especially those patients with RV dysfunction, and also it's more physiological. And secondly, the complication is less. Anatomically, you can see the 2 patients on the left side is more better coaptation. The lines are very clear targets for edge repair, while on the right side, the gap is wide. There's no way where you put your clips. So this is technically would be more difficult. So it actually gives you some guidance when you look at this kind of images. So there had been red lights, green lights, yellow lights, similar to the mitral valve story. So their criteria for showing is in favor of edge repair or is unfavorable. So there have been strengths and weaknesses for TEER and TMVR. For TEER, it's flexible, it's low thrombotic risk, less chance of gelling the leads in terms of pacemakers, AICD. less theoretically low risk of acute RV offload mismatch. The weakness is the chance of leaflet detachment, residual TR, which links to mortality or survival, and the demanding procedural imaging. For TTVR, it's easy one shot and could eliminate all the TR, but sometimes when you eliminate TR, the heart may not be able to adapt it, it may not be well tolerated, and weakness will be also including device thrombosis, pacemaker requirement, and bleeding because the sheaths are much bigger. So adverse event is slightly higher than with device replacement, but definitely single leaflet detachment would be more with TEER. So, and one story is in the past we don't have good imaging. Now, one of the options is ICE, but some patients, when we see in the first screening, they do not have a good imaging quality for TEER, then maybe it's a good candidate for replacement. I think we look forward in the future with better technology for imaging guidance, then we can overcome this. Because overall, we don't want to choose patients based on their imaging quality. We really want to base on their physiological and also pathology for the tricuspid regurgitation. So I think we will not cover that, but trach valve is one of the options. If you can, this is definitely one of the gaps that it's good to fill in, but it really depends on the local setting because like in Asia Pacific region, the penetration of trach valve is even higher because TriClip and also the TTVR is not well penetrated around the region. It really depends on the individual center's algorithm strategy. And for us, heart team evaluation, TTE and TE assessment, and definitely if you think this is eligible for a TEER, then we'll go first. And if not, we don't want to just half-heartedly put in some clip and go away. CT scan is a must to screen for eligibility, both for TTVR. If it's good, then go for TTVR. If not good, let's go for bicaval valve. And if the patient had a clip already in place, we'd assess whether they would affect the TTVR in terms of anchor positioning. If not, then I think combination of HLH repair plus heterotropic bicaval valve implant is also an option. So thank you very much for your attention.
Thank you very much. We move on to Dr. Wujakowski. He will talk about the Croy valve.
Thank you very much. I would like to share some initial data from the early feasibility study. So there are clearly unmet needs already discussed and non-clippable patients and also patients with anatomy that's not really ideal for replacement may have additional option by treatment with this technology. So let me show you some features of the valve. So this is tri-leaflet bovine pericardial tissue valve, which is mounted within the stent, and the stent from the outer surface of the stent is covered with the with this bovine tissue. So it provides inflow during the diastole through the valve, but also it provides a platform of coaptation of the native leaflets around the stent. So this valve is mounted, it's anchored by the stent placed in superior vena cava, and there is a connecting mechanism that allows you to tailor the positioning of the valve to provide the sealing without getting in contact with papillary muscles or without the risk of embolizing. So this is a short video how this valve works. This is transjugular 26 French dry seal. Then this 22 French system is introduced. The valve is unsheathed, the stent opens, and then we position using different knobs the valve. Then the stent is deployed, and still you have chance to tailor the positioning of the valve, moving it deeper or shallower in the ventricle, and also there is a possibility of changing the orientation in anterior-posterior and septolateral direction. And then this stent is disconnected and the vascular access is closed. So this is pre-planned with a CT, and this is crucial what we learned from early cases. The stent should be oversized by 30 to 50%, anatomy of the SVC plays a role, and this CT should be done in a patient who's not completely dehydrated. I mean, it's not optimized as much as we can just to provide the information on worst case scenario of the SVC, because the change of the SVC size depends on the fluid status. So we try to evaluate the patient by the CT, and also it provides a way to plan the depth of implantation to avoid the contact with papillary muscle. So the Tandem 1 was the first in-man study done in Poland in 4 centers. And this enrollment included 11 patients with at least 2 years follow-up. And this was the feasibility study. So the patients were around 80, mostly female with high New York Heart Association class and poor quality of life. 80% of them were in massive or torrential TR. The LVEF was preserved, and AF was present in all of the patients. So this is the actual procedure. On the left, the valve is deployed by unsheathing the dry seal sheath. Then this coaptation valve is directed by angulation of this element up to 90 degrees. And then the valve can be positioned deeper or shallower, and can be moved more septal, lateral, anterior, and posterior. So there's a lot of maneuvers we can do. Then number 3 shows unsheathing of the self-expandable stent in the SVC. And still there is a chance to reposition the valve within the annulus to provide the best sealing of the TR. And as you see, despite very early experience, the implantation time was only 43 minutes. So this is relatively straightforward procedure. So the 30-day safety shows low incident of MACE. Early in the one of 3 first cases, probably because of less oversizing of the stent. There were 2 cases where the stent moved in the SVC towards the right atrium. So those patients were operated on successfully without mortality. Since then, the oversizing of the stent and the sizes of the stent were increased, and no such problems occurred. So 1-year clinical outcomes is the reduction of the TR severity and improvement in NYHA class, some improvement in quality of life, and 6-minute walk test. Of course, the N is 11, so we have to be cautious what we conclude based on 11 patients. But we have those patients already in 2 years follow-up, and there is a consistent improvement in their quality of life. This is one of the cases where the patient with a very poor quality of life was treated. And after implantation of the valve, you can expect moderate TR at the end. So it's not complete sealing of the TR, but this patient has really improved. And there are some signs in follow-up CT that the right ventricle remodels. So Tandem 2 is a multinational study already enrolling patients in the US and Europe. So it will be the largest trial to target this population of patients. And one of the ideas is that this valve may be useful in patients with pacemaker leads, and also in patients in whom the TEER was unsuccessful, because you can imagine implanting this valve if the clip is relatively close to the commissure, there is enough space to treat those patients. So let's see what this larger trial will show. Thank you.
Thank you very much. Next speaker will be Dr. Hahn, a novel vertical spacer for tricuspid irritation, early experience of the Pivot TR system, which has been developed here in Korea. Please go ahead.
Thank you, Chairman. Good morning, everyone. And these are my disclosure. Pivot TR is a novel, self-centering vertical spacer without a traumatic anchoring structure. The procedure is relatively simple, typically less than 20 minutes, and does not require complex imaging guidance such as TEE or ICE. It can deal with TR with a large gap and is less dependent on annular or RV size. The catheter can be retrieved percutaneously if needed within 2 to 4 weeks. The Pivot TR device was invented by Professor Junhong Kim from Busan National University Yangsan Hospital and made by Tao Medical, Yangsan, South Korea. Let me introduce the Pivot TL family very briefly. Pivot balloon was made for temporary indwelling for a couple of minutes. The concept was proved first in human study, and the results was recently published in Korean Circulation Journal. Today, I would like to focus on the pivot bridge system. It was designed for short-term implantation, typically less than 1 week. It can bridge to other treatments such as surgery, device, or medical treatment by the effective TR prehab. It consists of a 2-part pivot axis and expandable 3D leaflet. The guide wire is located into the right lower pulmonary artery, and the Pivot TL delivery system is advanced over the guide wire, and then the delivery catheter is gently unsheathed to allow the 3D spacer to expand, and further unsheathing of the delivery catheter can make the spiral anchor to be deployed at the IVC. It is made of nitinol mesh with EPTFE coat. Its width ranges 9 to 15 millimeter, and it needs 20 French introducer. This animation briefly shows the procedure. The guide wire is located into the right lower pulmonary artery, and then delivery catheter is advanced over the wire, and the catheter is gently unsheathed to allow the spacer to expand across the tricuspid valve, and further unsheathing can make the spiral anchor to be deployed at the IVC. In this study, the mean procedure time was 47 minutes, and all procedure was guided by fluoroscopy and TTE only. In this first in-human study, we enrolled 15 patients with a severe to torrential symptomatic TR. The primary endpoint was major adverse outcomes. 10 patients underwent open heart surgery after stabilization, TV repair in 9 and TV replace in 1. The catheter, the pivot bridge was manually retrieved at the time of a surgery, and 5 patients were stabilized by medical treatment. In these patients, the pivot bridge was retrieved by percutaneously. We had the echo and a CT collapse. The mean age was 68, and chronic atrial fibrillation was found in all patients, and the comorbidities was found in substantial number of patients. In echocardiography, annulus diameter was about 5 centimeter, and coaptation gap was 10 millimeter. 13 patients had massive to torrential TR. 2 patients had a severe TR. In CT examination, LV and diastolic volume was 330, showing all patients had far advanced severe to torrential TR with markedly dilated RV and IVC. Its characteristics challenges the treatment by other devices. Let me share a representative case. At baseline, torrential TR was found with markedly dilated LV, RA, D-shaped LV, and IVC plethora. During implantation of a pivot bridge, TR was markedly reduced with the disappearance of a D-shaped LV and IVC plethora. Procedural success defined as 1 grade reduction or more was achieved in all patients. Effective regurgitant orifice area and vena contractile width decreased significantly. And during the pivot bridge implantation, torrential TR was not found, and 1/3 of the patients showed mild to moderate TR. Renal function improved, and peripheral edema decreased, and the functional status assessed by NIA class was also improved. CT shows LV and diastolic volume was decreased by 8%, and the 3D TTE showed the annulus area decreased by 10%, suggesting favorable RV geometric change after pivot bridging. The treatment effect of pivot bridge was consistent in patients with torrential TR and those with large annulus. Major adverse outcomes occurred in 1 patient, gastric ulcer bleeding, and the minor adverse outcomes occurred in 3 patients, puncture site hematoma in 2, and transient bacteremia in 1. Spacer position slightly changed in 2 patients due to the mismatch of spiral anchor and IVC size, 2 big IVC, but TR reduction was maintained without causing any other adverse effect. In summary, pivot bridge, the vertical TR spacer significantly reduced the TR in patients with suboptimal medical control, leading to symptom alleviation and stabilization during short-term implantation in this first-in-human study. Procedure for pivot bridge can be done relatively easily, quickly, and safely under fluoroscopic and TT guidance. Additionally, pivot bridge prompted a favorable change of TV geometry and LV volume reduction, which can adapt the patients to subsequent corrective procedures, such as open surgery or other devices. Therefore, pivot bridge can play an adjunctive role in patients with a severe to torrential TR on top of medical treatment. And now the pivot extended was developed, and the first-in-human study will start soon. Thank you for your attention.
Thank you very much, and we move on to Dr. Sung, current status of tricuspid valve interventions in Asia-Pacific region.
Thank you for having me here to present the current status of tricuspid intervention in Asia-Pacific region. This is my disclosure. We all know that the prevalence of severe tricuspid regurgitation in Asia-Pacific is similar to the data reported in North American and also European registry. But the difference is that there would be more degenerative and as well as the rheumatic causes of tricuspid regurgitation compared to the Western country. However, the patient in Asia-Pacific always present their symptoms very late. until they have really done RV failure. However, the device availability and also reimbursement policy across the country will be very different. So this is now the available technology in Asia Pacific involving the edge-to-edge repair, annuloplasty, also tropic, and also heterotropic valve replacement. Compared to Professor Sievert presented yesterday, 35 devices in Europe, that is really less in Asia Pacific. The most available device would be the TriClip, which could be available in majority of Asia Pacific country, and also the trick valve might also more widely available. The K-clip is just has been approved last month, so therefore the Hong Kong probably would have that. Otherwise, the other technology either can assess by compassionate use or in clinical trial. So this is really limited device availability in Asia Pacific. We all know that very good criteria, Glasgow, for the prediction of procedural success in tricuspid procedure involving not only the anatomy, tricuspid anatomy, but also the image quality. So when you have a patient with a torrential TEER, if you can have a very good trajectory and image and also a challenging but remain feasible anatomy, you probably can able to achieve residual equal or less than 2+ TEER with multiple devices. This is the data from my institution that the TriClip was approved in 2023, and that year we treat the patient, almost 40 patients, mean age 75. Compared to the surgeon, a surgeon in Taiwan is really reluctant to do isolated tricuspid surgery because at the beginning, patient really have limited symptoms with diuretics, but when they go beyond the threshold, a point no return, they are not able to do the surgery. And comparing to that, the surgical patient, mean age 56, but the 30-day mortality 6.5, and comparing to TEER, which is 0. We know that TEER is really a procedure. However, we still have many patients presented by this anatomy with very huge gap. Torrential TEER is not able, and very tethered septal leaflet, which is not suitable for the TEER technology. However, given patients have really progressive symptoms, so therefore we would like to try, but we still are not able to reduce the of course, before procedure, we understand. And even worse, that the patient have septal tether, leaflet tear within 30 days, so which may even worse the condition. And 1 year later, when the lost valve is available for compassionate use, we do a lost heart clip and then to implant the valve, so which now, the image now showing that the valve replacement can really abolish all the TEER. The lost valve have very specific feature including for the anchor system, including the 2 leaflet grasper and also septal anchor and also the large atrium disc, which comparing to the evo valve, which may partially rely on the annulus anchoring. So this is the data, 1 year data from the travel study, using actually is the older system, transatrial lost valve system, to treat more than 100 patients, showing that the 1 year mortality is about 10%. The patient really can get benefit in reduction TEER as well as an improvement in functional class. The 30-day new pacemaker implantation rate is less than 1% and less than 2% within a year, comparing to evo valve. This is really nice to prevent the conduction disturbance. The annuloplasty technology, the K-clip, is designed according to the surgical approach, the K procedure, to bicuspidize the tricuspid valve. So it can introduce a focal annuloplasty to bicuspidize the tricuspid valve. It's comparing to the TEER procedure, the image requirement, which would be a bit less. So the first step, you introduce the sheath into the right atrium, and then you steer the system toward the annulus, what you are going to treat. And then you can screw in the screw into the annulus, and you pull, you open the clamp arm, and then you pull the annulus up, and you can fold the
fold the annulus, and then you can achieve the focal annular spiral effect. Of course, during the procedure, you have to very watch out for the right coronary artery flow. This is the 1 year data from the pivotal trial for China FDA approval that demonstrated the K-clip can really produce a very durable and TR reduction within a year. 80% of them will have equal or less than 2 plus MR. And it's nicely showing that the significant annular spastic effect immediately after the procedure, not only on the septolateral diameter, but also the anterior posterior diameter. The patient can really get a symptomatic benefit from the TR reduction. And if the patient have really a torrential, a really huge tricuspid annulus, you can also have modified procedure to have true K-clip procedure to shorten the AP and also septal posterior. And if you left the anterior septal regurgitation, you can also combine with the TEER technology. Of course, again, you have to very watch out the right coronary artery flow during the whole procedure. And the other available heterotopic valve replacement that we already, that is palliative treatment for TR for the symptom relief. So it can really nice to even the patient have in situ pacemaker. So this is the first compassionate use in my country. So two device, and then you can, also we did not treat TR, but we can reduce the regurgitation flow into the liver, into the plant. Although we don't have data in Asia Pacific, according to the TRIC Euro, which nicely showing that a patient can really get symptomatic benefit, and even we don't treat TR, but it seems that from the data, we still can get RV remodel. So for the future challenge, I think we have the same challenge on reason control medical therapy as the Western country. But on the other hand, we still lack of the novel technology. The availability would be the critical issue, and the other issue would be that the reimbursement system across the country in Asia Pacific might be vary. Thank you for listening.
Thank you very much. Yeah, it's true that yesterday I said we have 34 devices, but I also said these are under development. And as you may remember, some of them are skipped already. So we don't have so many devices in Europe, just to mention that. Okay, are there any questions from the audience or from the panelists to any of the talks?
Yeah. Yes. Okay. I have a question for Professor Hahn. I think the pivot bridge device is very interesting because at least in Thailand, we have the same problem. They come so late. Do you have any experience for bridging to TEER? Because I saw that you had data for bridging to surgery. What about to TEER?
Yeah, that's a very interesting concept, and we are expecting those kind of a procedure. But unfortunately, TEER is not available and not approved in South Korea yet. But after the introduction of TEER, probably the combination of a pivot bridge and a TEER can play a role in patients with severe symptomatic TR.
I have a question to your device. So I appreciate the advantages as a chronic implant. I'm not sure about the bridge concept for two reasons. One is, how did the surgeons appreciate this procedure? I mean, they just can go ahead and fix the valve and that's it. And also, I noticed that in your trial with the 11 patients, the average weight reduction was only 1.5 kilogram, which is for a patient who has peripheral edema, actually very small reduction. So what is the value of this bridge concept?
Yeah, the first thing is if TR decreased, we can reduce the diuretics, and the renal function is preserved, and sometimes the GI congestion is improved, and the patient can eat better. So the patient conditions are much improved before surgery, and that can turn in the results in the good, better outcomes after surgery. And the second thing is sometimes surgeons are concerned about LV intolerance after the TR repair or TR replacement, but the pivot bridge a kind of can be a test for TR reduction and RV intolerance. So the surgeons are in favor of the pivot bridge.
Okay, perfect. Thank you very much. Any other? Yeah.
Yeah, I think in Malaysia, because of cost constraints, sometimes if you have MR and TR, we do the procedure together, mitral and then we run into a lot of problems in terms of imaging. And we don't have eyes available for all patients. This is because of cost. Now, do you have any experience doing, would it be better to stage, just do the mitral first, then later reassess the TR, or would you do something like this?
I think this question is better for Dr. Song. You mean pivot bridge system or in general MR-TR treatment? Your question.
Yeah, we use mitral clip and triclip. So we
Yeah,
do
yeah,
it
yeah.
together.
Yeah.
But imaging is definitely a problem when you have 2 or 3 clips on the mitral side. And even if you take transgastric view and all the other views, without eyes, you might have problems doing the triclip.
Yeah.
But because of cost constraints, sometimes we are forced to do that.
Yeah, the question is better for you.
I think that the clip at mitral position might not really affect the tricuspid images. Even the annulus probably would. So if it is at the center, I don't think we don't have that issue. Especially we remain on rely on the transgastric view. So if the patient have good transgastric image, we will go for tricuspid procedure. But if the patient did not have good transgastric image, we probably would really hesitate to do that, given that the 4D eyes in Taiwan is not available. So that.
I have a question for Simon. You showed cases where you prefer the valve implantation because of big gaps. How far do you prepare these patients? When you see a gap of more than 1 centimeter, do you diurese them? Do you use PEEP during anesthesia? So before you decide to go to a valve, what is your current strategy?
Yes, so definitely we tried our best to see if we can do repair, because replacement is my second choice, definitely. And so we have the patient, we really have to assess the TR first, because like sometimes it's very dynamic depending on fluid status. So if the patient admitted 1 or 2 weeks, actually stay in the hospital for aggressive diuresis, plus some people maybe inotropic support, diuresis, and let's see how it goes. And sometimes we may need to use some medications to improve the RV, and let's see how it goes for overall assessment and review. But there's no definite guidelines, but we just try to diurese as much as possible, not to the level of dehydration or kidney failure.
So overall, how many clips in tricuspid position, how many valve implantations, and how many trick valve type of valves?
So do you mean in my center?
Yeah.
So my center around triclip is around 100, and so for implants is around 20, and bicaval valve around 10.
Okay. Yeah. Any other question for Simon?
Okay. So can I ask Simon?
Yeah.
Yes. So regarding TER and TTBR, so of course anatomical feature is very important, but RV function is also very important.
Yes.
So so TTBR can eliminate TR completely. So if patient has very poor RV function, so that may lead to very bad condition. So do you have any cutoff RV function, or do you have any timing of TTBR like that?
Yes, so it's a very important question, because it's difficult to predict, but definitely if a patient has very poor RV function, then they are the candidates who cannot tolerate the sudden elimination of the TR. And so we do a very comprehensive hemodynamic assessment with right heart catheterization. There are parameters that we can take into consideration in addition to RV function, like the LVOT coupling and a lot of these kind of things that put into considerations. And we avoid to do patient in acute setting because their heart failure is ongoing. We try to stabilize it in front of our eyes in the hospital, so they can, even they have severe TR before the operation, they can move around, they're in a good shape. And we have a very intensive post-operative support in the ICU, they usually need to give some adrenaline infusion to improve the RV function to help them tie over. So it really case by case, but really very, very poor RV function, then that is a genuine risk. So maybe other system, maybe the check valve or other selection that may be also considered in those scenarios. But what we could do is to learn more from those patients. We do comprehensive perimeter assessment, careful post-op monitoring. But overall, they're too sick because overall the patients are difficult to predict. But these are things could occur. Even very successful procedure, the patient can die. So it's just a tough question, but it really occurs.
Simon, you mentioned about the patient might encounter RV failure after the valve replacement. Have you ever tried, the pH medication, which is suppose some would try that to, improve reduce the pulmonary vascular resistance, try probably relieve the afterload of the right ventricle.
Yeah, for very selected patient, yes, but we don't have like comprehensive experience on this. But I think selected patient could consider. Yeah.
It cannot be that none of the audience has questions. We have 2 microphones, so please, if you have any questions, let us know.
Sorry, can I have a question? Sorry. I have a question for both the Dr. Len and the Dr. Song, because you both have the experience of the Lux valve. Do you think it's a good idea to gel the lead, pacemaker lead, when you replace the Lux valve for the long term? So if the patient has pacemaker lead, was this lead influence your decision making to replace the valve or to repair the valve? And the other question is, as the Dr. Song just showed us, the Lux valve could be the bailout option for the failed tri-clip. Is that the general case or only very special case you can do that? Thank you.
Definitely a very special case. So it's not a general case that we can, can try the TEER technology followed by the valve replacement, orthotropic valve replacement. I don't think that it's not easy. Even you still have, you did have technology to elastic the septal leaflet, but I think it remains challenge.
Yeah, I think the positioning of the pre-existing clip is very important. If it's in a commercial area, then it's not blocking, especially the septal anchor, then it's doable. But then if it have potential influence on the anchoring mechanism, then better to try either to do elastica to remove the clip before the deployment or do adjunctive procedures like the bicaval stenting. And for the valve that we only have the experience of Lux valve for pacemaker leads, and we actually had a multi-center study going on with the pacemaker leads and also Lux valve. So, but then before going to that is to assess the leads before implant is very important. First is the tension of the lead, because most of the time if it is a lead causing the TR, then it's because of very strong tension that is splitting the septal leaflets. The more tense the leads, the more chance of the interference or capturing or have erosion of the leads affecting the function. The second thing is the mobility of the leads during the implantation. You can try to use a pigtail or use a cavity to test the mobility. And also when you position it, try to avoid the anchor directly pressing on the leads. So there are lots of technical considerations, but this is not well studied, but then I think it's doable. And so far the cases are all right, but assessment is important before thinking about TTVR for this kind of cases. But still, TEER is the number one thing in case you have a lead. So this is limited experience from us.
Yeah, I might have a question for Dr. Hahn, Professor Hahn. That we mentioned that the patient with very, depressed RV function might not able to get a new valve inside you. So you just mentioned your technology with pivotal bridge. Have you ever assessed the right ventricular function by either index that to see after that the patient either can get improvement in RV systolic function, intrinsic RV systolic function, and also what about the renal the liver function? Because our surgeon always reluctant to do the surgery because patient already have elevated bilirubinemia, because that is really carry significant high risk.
Yeah, for the second question, the LFT improved as well as the renal function. And the first question, I'm not an imaging specialist, but in terms of TAPSI, there is no significant improvement because the duration of implantation was only 1 week. So, but the pivot extended is developed for permanent implantation, so we expect long-term results, and we hope the RV function can be improved with a pivot implant. And one of the beauty of the pivot bridge or pivot TEER system is it does not damage to tricuspid valve leaflet. So if patients have to undergo surgery, the surgeons can valve repair instead of a valve replacement. But if TEER fails, most patients have to undergo tricuspid valve replacement.
Yes, may I have a question for Dr. Sung, probably, about the heterotopic valves, the bicaval valves for TR. This is obviously not treating the primary cause, and it's probably giving more pressure and more volume to the RA, probably, which will then give a afterload pressure to the RV. And we all know that the RV is very sensitive to pressure. Will that have any clinical impact in the patient? Well, obviously the LFT may get better after a valve, but what about the RV itself?
Actually, I only have limited access for the cable valve, so maybe Simon can answer the question. But I have the same idea, same concept with you. So it did not really treat the TR, but we did see the RV remark. I don't have.
Yeah, I think most of the time the patient can improve clinically. They may be long hospitalization. Eventually they can go home afterwards, but then they still have the same clinical course. They still come back with hospitalization, and they have the same pathway for mortality and RV failure. So echo-wise, there's nothing that we can generate from that, because maybe it takes some time for remodeling to occur as it is described in the European experience, but maybe the patient deteriorates so fast, especially those cases when we use this system. Already there are those who are not eligible for TEER, not eligible for TTVR. They're very burned out heart, huge dilated heart, very poor RV function. So I don't have that conclusion yet, but clinically the patient can go home and have a better life afterwards, but at least a short period of time.
Yeah, but in our experience, we didn't see any reverse remodeling because it's quite short. And after the last valve is available, I no longer a fan of the bicaval valve.
I think in the trial, the volume of the right atrium decreased, right? Which was surprising for me because I expected that they would increase. Yeah. I have a question to Wojciech in that regard. So your concept, the Croy valve, we cardiologists always look for remodeling. So if the heart remodels, then the Croy valve may move out of the plane of the tricuspid valve. Is that something you are concerned about, or something you have observed?
In limited number of cases. So there is like a little bit of reduction of tricuspid annulus. And because this valve, the size of the valve, the diameter of this valve is 22 millimeters. So there is enough space between the annulus and this spacer to allow for coaptation. So even if there is less annular dimension, still the mechanism of sealing will be the coapting of the native leaflet around this valve. So I don't think there will be enough remodeling to make the long axis of the right ventricle small enough to push this valve, because the positioning of this valve is probably like 30-70 across the annulus. So even if there is a reduction of left ventricle size by like 3 to 4 millimeters, it wouldn't make this valve, which the length of this valve is 26.
Okay.
So it wouldn't really matter, in my opinion. We also checked this valve with echo in different positions, like standing, sitting, left lateral, right lateral. So nothing really changed.
Okay.
So let's see with larger number of patients.
Okay, thank you very much. Okay, so I think we have no further questions. Closing remarks from your side?
wonderful session. So thank you for excellent speakers, panels, and audience. I would like to close this session. Thank you.